Welcome, everyone, to today's session of our Survivorship series, Gastrointestinal Cancer Survivorship Key Issues, led by Leah Biller and Kathleen Boyle. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the Survivorship team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center, as well as the Survivorship website. For those of you watching live, if you have any questions related to today's program, please feel free to utilize our chat feature throughout the session. At the end of the session, your questions in the chat will be used to moderate our Q&A. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource center or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the session over to Kathleen and Leah.
Hi all, my name is Kathleen Boyle. I'm a PA at Dana-Farber, and I have had the pleasure of working with Leah Biller for several years. I just want to start with an outline of the things that we're going to hopefully accomplish today. We're going to give some background on the GI cancers that we're going to review the symptomatology and ways to manage side effects related to these cancers and their associated treatment. We're going to hit some of the key issues, including treatment-related side effects and psychosocial toxicity, and also review some of the resources and supports that Dana-Farber has for patients.
Okay, so first, just a little background. Sorry. When we're talking about GI cancers, we're actually talking about an enormous number of different cancer types. As you can see here on the picture, there are many different organs that we take care of, and we're going to quickly talk through briefly how we treat many of these types of cancers of these organs. You'll see that some of the side effects may depend very much on what type of treatment was given. So esophagus cancer, patients can present with difficulty swallowing, weight loss, hoarseness, cough. For localized disease, sometimes we can use endoscopic procedures. Sometimes patients undergo surgery with removal of part of their esophagus. And sometimes we use chemotherapy and radiation in part with surgery. And for systemic therapy for cancers that have spread outside of the esophagus, we use things like chemotherapy, targeted therapy, and immunotherapy, which we'll talk about more as we go through. And similarly, gastric cancer patients can present with many of the same symptoms. We can treat localized disease similarly to esophageal cancers, and we have similar options in terms of systemic therapy.
So pancreas cancer, some of the ways that this presents is patients will have jaundice or yellowing of the skin or eyes, some weight loss, back pain, nausea, vomiting, and the presence of blood clots. You'll start to notice a trend that a lot of these therapies have similar options for localized disease, including a combination of surgery with chemotherapy and radiation. And then systemic therapy options for metastatic disease include chemotherapy and targeted therapy. Moving on to the liver cancer or hepatocellular carcinoma, presentation includes similar symptoms as listed in the last slide, like jaundice, weight loss, back pain, right upper abdominal pain and fullness, and itching. And again, localized therapy includes surgery, which could include removal of part of the liver, as well as liver transplant, ablation therapy, or embolization therapy. While systemic therapy for metastatic disease, which is disease outside of the liver, would be targeted therapy or immunotherapy. And thinking about bile duct cancers, also known as cholangiocarcinoma or gallbladder cancer. Again, we look at similar symptoms from presentation like jaundice, weight loss, pain, and fullness in the abdomen. And therapy for localized disease includes surgery, which might mean removal of the gallbladder or part of the liver. It could include the Whipple procedure, which involves some removal of the pancreatic head, as well as some organs in that area, as well as liver transplant. Additionally, for localized disease, ablation therapy, embolization therapy, radiation therapy, and chemotherapy are options. And systemic therapy for metastatic disease includes chemotherapy, targeted therapy, and immunotherapy.
Neuroendocrine tumors can present in a variety of ways, including what we call carcinoid syndrome with flushing, sweating, diarrhea, wheezing or asthma-like symptoms. Patients can present with high blood pressure, significant fluctuations in blood sugar, abdominal pain, diarrhea. Again, similar types of therapies for localized disease that we've talked about. And for more advanced disease, we use things like somatostatin analogs, targeted therapy, immunotherapy, and nuclear medicine type therapies. For colorectal cancer, patients can present with changes in bowel patterns, blood in the stool, rectal or abdominal pain or pressure, weight loss, and iron deficiency anemia. Localized disease can be treated again with surgery, chemotherapy, and radiation, and sometimes immunotherapy, depending on the specifics of the case. And similarly, we use these same types of agents in the more advanced setting. And for anal cancer, patients can present with itching or bleeding. They can feel a mass or pain and fullness in the area, as well as changes in their stool pattern. Therapy for localized disease often includes chemotherapy and radiation, sometimes surgery, and then again for advanced disease, chemotherapy and immunotherapy.
So now we're going to talk about some of the key issues, including treatment side effects, because with all of these therapies that we've listed between targeted therapy, chemotherapy, immunotherapy, surgery, and radiation, there are obviously expected side effects, some of which we can expect upfront, and some of which we need to see what happens before we make a treatment plan. Some of the common chemotherapy and side effects include this list, which you'll see is quite extensive. We expect that people could have issues with nausea or vomiting, changes in their appetite, which could result in weight loss, things like fatigue or mouth sores, changes in bowel movements, either leading more toward diarrhea or constipation. We could see increased risk of infection and fever and chills. We can see changes in skin and hair, also the potential for allergic reaction, as well as blood pressure issues, issues with delayed wound healing, as well as autoimmune reactions. So let's go through some of these more specifically. First, we're going to talk about nausea and vomiting. So there are ways that we can anticipate that patients may have more or less nausea or vomiting, depending on the type of chemotherapy that they're getting. And in those settings, we would use pre-medication, which means these are medications you don't need to ask your doctor to add, that they're part of the treatment plan that can either be maintained, increased, or de-escalated depending on how significant your nausea is. We're going to talk about kind of the formal category of the drug, but also the names of the drugs so you know what to ask for when you're having your next conversation with your doctor, nurse practitioner, PA, or nurse. So some of the pre-medication medications include steroids like dexamethasone, Ativan, which is a benzodiazepine, antiemetics of a certain class, also known as Zofran, and antiemetics of a different class known as aprepitant. So these are types of medications that can be layered, combined, or given sequentially to most effectively control nausea and vomiting immediately around the chemotherapy period. And then at home, there are medications that you can take, like Zofran, dexamethasone, Ativan, similar ones to the ones that were listed above, but also the addition of something like Benadryl or another nausea medication known as Zyprexa. I think one concept that's really important to know is with these medications, there may be times right after treatment where they're a little more important than other times. And sometimes the treatment regimen that you use for nausea will escalate or de-escalate depending on where you are in your cycle. We'll also talk about loss of appetite and weight loss. So things that can stimulate your appetite include steroids, things like dexamethasone. It can also include cannabinoids. We have the ability at Dana-Farber to prescribe a medication called Marinol, which isn't formally a marijuana product. That can be pursued with licensing from a provider within the community. But we offer this medication Marinol to kind of help stimulate the appetite. Other appetite stimulants include medications like Remeron. Sometimes we use antidepressants. We also rely really heavily on our nutrition colleagues because they are a wealth of information on ways to increase caloric intake and focus on protein and good fats. Sometimes acupuncture can be incredibly helpful for loss of appetite and weight loss, as well as thinking less about 3 large meals a day and more like 5 to 6 small meals a day and snacking whenever possible. Chemotherapy is very well associated with fatigue as well. So things that we use to prevent fatigue include steroids again, but also some stimulants. Sometimes we will use Ritalin or methylphenidate to kind of help increase the level of energy that people have while going through this therapy. We can also see mouth sores. So there are several ways to treat mouth sores and sometimes ways to help prevent them. We use saliva substitutes like Biotene mouthwash, Biotene oral gel, and mouth coat to help provide some hydration in the mouth to help prevent mouth sores. We can also use mouth rinses. And typically the way we think about this is you put a little bit of baking soda or salt in a cup of water. But ultimately over the course of the day, you're probably not going to do that multiple times. So sometimes I'll ask folks to take a 2-liter bottle, add 3 tablespoons of either salt or baking soda, and then leave that bottle somewhere convenient in your home, like the bathroom or kitchen sink, where each time you walk past, you can shake it up, take a bit, swish, and spit, and then you don't have to worry about making individual cups each day. We also think about things like sugar-free candies. Lemon drops are known to stimulate saliva production. There can be dexamethasone mouth rinses. Magic mouthwash, which is a combination of some medications to help decrease inflammation and numb the mouth and esophageal surface to help decrease the irritation that mouth sores create, as well as nystatin mouthwash or clotrimazole troches. These are used really if someone has thrush. And the way we identify thrush is looking inside the mouth and seeing this thick coat of kind of white goop on either the tongue or the mucous membranes. Those are things that we absolutely would want to use nystatin mouthwash or clotrimazole troches to treat. Next, we're going to talk about diarrhea, and I can get the slide there. Here we go. So sometimes we use antidiarrheals. I've listed the formal names here, but the first one is Imodium. That's something you can get over the counter. The next one is called Lomotil, and that requires a prescription. The thing about either of these antidiarrheals is that they're okay to use, but I would always check with your oncology team first. Sometimes we need to be sure that there's no infection that could be creating the diarrhea, and then using one of these medications could actually be problematic. So always check with your oncologist before attempting one of these medications, but know that Imodium is available over the counter and Lomotil is a prescription medication. Imodium is kind of the first level, Lomotil is the second level, and then that next bullet point of the opium tincture is kind of the third level and the strongest medication we have to help prevent diarrhea. Some of the other kind of lifestyle modifications is we ask people to think about including foods from this BRAT diet more regularly in their food choices. BRAT stands for bananas, rice, applesauce, and toast. So think about those really binding agents that can kind of help your stool get more bulk. And ultimately, we know that chemotherapy is what leads to the diarrhea formation. So sometimes we need to adjust the chemotherapy doses because if diarrhea is a significant problem, this might be the most effective way to manage it. Next, we're going to talk about the seesaw of constipation. And I say that specifically because sometimes patients will have lots of issues with diarrhea and then flip over to constipation. So managing bowels is a constant effort and something we ask about frequently in visits. Some of the medications that are laxatives include Senocides, something like Senocot or Senocide T. Polyethylene glycol is better known as Miralax. And if people are really constipated, sometimes we have to use milk of magnesia or magnesium citrate. And then there's also lactulose, which is a prescription laxative. These medications are listed on this slide almost in the order of their intensity because they kind of further and further escalate the intensity of the drugs to help relieve your constipation. Another thing to consider is a stool softener, something to keep the stool nice and wet so that it's able to pass with no problem. Plus hydration and exercise. Moving your body in whatever way you can and adding some additional fluids can help your stool move more easily. Next is neuropathy, which I would say is one of the most frustrating common chemotherapy side effects for folks who are receiving the therapy as well as the folks giving the therapy. Often this is related in GI cancers from oxaliplatin chemotherapy. But one thing to really file away is that this neuropathy can sometimes behave unpredictably. Some people can see how their neuropathy mounts dose by dose, so we can have a clear conversation on what to expect. And sometimes neuropathy can come from out of the blue with significant side effects. So the medications we think about for neuropathy include duloxetine or Cymbalta, gabapentin or Neurontin, and pregabalin. There's a lot of data to suggest that acupuncture and massage can also help for people who have neuropathy, as well as returning back to the conversation with your oncologist about the intensity of your symptoms, as it may require a chemotherapy dose or schedule adjustment. There's some anecdotal data, meaning it hasn't been verified by a clinical trial, but some people have some improvement in using alpha lipoic acid and vitamin B complex for nerve regeneration and healing of neuropathy. This isn't something that always helps. Some people find a lot of relief, some don't. So it's something to consider, but not necessarily a known solution for neuropathy related to chemotherapy. This is a systematic review that included 8 studies showing the prevalence at any grade of peripheral neuropathy as folks went through chemotherapy. You can see that in terms of the further that someone is on chemotherapy, the more significantly the neuropathy was able to fade after they completed their therapy. So at 6 months, approximately 58% of folks noted symptoms, at 1 year, 45, at 2 years, 32, and at 3 years, 24. However, for the 24% of patients still experiencing neuropathy at 3 years out from therapy, it can be incredibly bothersome. And another symptom we think about related to chemotherapy, specifically with our GI cancer agents, often from fluorouracil or capecitabine chemotherapy, is hand-foot syndrome. Sometimes this can appear as red, hot, irritated, and peeling hands and feet, often on friction points, like on the balls of your feet or the heels of your feet. Very often, the way that this is best treated is with a drug interruption and dose modification, just like we've talked about for other side effects. Let your oncology team know what's happening so they can make appropriate side effects to help manage this therapy. We ask for folks to use moisturizers, sometimes medicated creams like urea cream, and sometimes even topical corticosteroids. All other supportive treatments include wound care for any erosions or ulcerations. Topical cherolytics are basically medications that help break apart those hard and rough surfaces that are made on those friction points, and sometimes analgesics for pain control.
And switching gears a bit to immunotherapy. So, immunotherapy works very different from chemotherapy, and a lot of the side effects are different than the ones that Kathleen went through very nicely. Immunotherapy works by stimulating your own immune system to attack the cancer. And side effects tend to happen when your own immune system makes mistakes and instead of just attacking the cancer, attacks parts of you instead. And so I tell people really any organ system you add an itis to, it can cause. And you'll see here multiple organs have potential implications from side effects from immunotherapy. Now, many of these side effects we can treat with steroids and other immunomodulating agents, but some will persist even after we finish with the treatment, and patients may need to be followed by different specialists like cardiologists, endocrinologists, pulmonologists. It can really cause a wide array of different side effects involving many of the different organs in the body. In terms of radiation, which we use in many different cancer types. Short term, people can have fatigue depending on what organ is being radiated, especially in the pelvis for like rectal cancer. People can have urinary symptoms and diarrhea. Often there are skin changes from the radiation impacting the skin, and it can affect the blood counts just like chemotherapy. And long term, again, depending on what type of radiation, like radiation in rectal cancer to the pelvis, causes sterility, premature menopause. Radiation can also cause late bone complications and rarely even secondary cancers. And fertility is a really big problem for a lot of our rectal cancer patients because, as I said, patients that are receiving radiation um, will typically have ovarian failure and male infertility with the levels that are given to the pelvis. And it's very important that ideally before even beginning treatment, that patients of childbearing age are counseled about this because we often do recommend sperm banking or egg or embryo banking before beginning a treatment with radiation. And then there are many other potential sexual side effects of radiation to the pelvis, including vaginal stenosis, dryness, pain with having sexual intercourse, erectile dysfunction, and sexual dissatisfaction of all. So these are really important to talk to your doctor about if you're noticing any of these potential side effects, because there are supportive care and treatment options that we can recommend for patients. And then surgery, which for many of our patients, we hope to be able to bring them to. Depending on what organ that is going to have surgery, you can imagine that there are different potential side effects. For surgery where patients are having their esophagus or stomach removed, they can be at risk for developing certain infections. Their ability to eat and how much they can eat and how they eat will change. And some have trouble initially, especially with weight loss, but that can be an ongoing struggle. Patients can have nausea and changes in their voice. Pancreas surgery and sort of biliary surgery as well can cause some similar symptoms, but also specific to the pancreas, it can lead to diabetes, where patients are requiring insulin, or pancreatic insufficiency, where patients require enzyme replacement for their pancreas. And I'll spend a little bit more time talking about bowel surgery, like what we see for colon and rectal cancer patients. You can have diarrhea, incontinence, clustering of bowel movements, urgency, and some patients have ostomies, which they need to learn how to manage. And talking a little bit more about GI cancer and specifically rectal cancer surgery for patients that are getting a low anterior resection, which is a type of surgery where they don't need an ostomy to remove their rectal cancer. LAR syndrome is an unfortunate side effect that can be very debilitating for patients. Basically, anyone who has one of the symptoms that you see on the left, leading to one of the consequences that you see on the right, we consider that to be LAR syndrome. So these are patients who are having lots of altered bowel patterns, increased stool frequency, sometimes discomfort, urgency, feeling like they can't go out of their house because they're worried about where the bathrooms are, and can be really impactful and bothersome to patients. There are supportive care and treatments that we use for patients who have this particular issue, starting from things like just adding in fiber, supplemental fiber, like Metamucil, loperamide or Imodium that Kathleen talked about. There are some other studies looking at doing physical therapy and sacral nerve stimulation. But for some patients, despite kind of all of these supportive cares, if they don't have improvement with their LAR syndrome, they may need even a permanent stoma or ostomy. And patients who have rectal cancer where they need to have we call an APR surgery, which is removing the lower part of the rectum that involves the sphincter. They have an ostomy where their bowel is reconnected to the skin in their abdomen, as you see in that picture. And patients can live very full, long lives with ostomies, and many do. But there are a lot of resources for patients that are new to having ostomies. It can require a little bit of education at first, but there are lots of support and resources. You can basically find anything you need on Amazon in terms of bathing suits or covers. There's a whole market for supporting patients who have ostomies. But at the beginning, it can require a little bit of learning and definitely talk to your team about the many, many resources that exist to help manage new ostomies.
So next we're going to talk about some of the key issues, including psychosocial toxicity, because I think it's really important to remember that while we spend a lot of time talking about physical side effects, that there are mental and spiritual side effects related to treatment, to diagnosis, to talking to your family about this, talking to friends. And so we really need to prioritize care of the whole person. Associated with this cancer diagnosis and therapy includes concerns with mental health and mental wellness. People can feel depressed. They can have depressive episodes or formal depression. They can have anxiety, sometimes with the nickname scanxiety, right before you have those scans, then the days leading up to reconnecting with your team. It can be incredibly anxiety inducing. This is a roller coaster of emotions, and also this can sometimes cause major life changes and transitions. You may need to leave your job. The group of friends that you spend most of your time with may change during therapy. So it's really important for us to acknowledge all of the ways that this cancer diagnosis can touch an individual. It's really important to discuss these concerns. At Dana-Farber, one of the things that we really hope to accomplish is taking care of the whole person, and we can't take care of you entirely unless you tell us what's happening in your life outside of just the chemotherapy and the medications that we prescribe to help with side effects. It's important to know and to acknowledge that cancer can be costly between medication co-payments, missed work, parking, gas, babysitters, different ways that cancer can cost money. There is absolutely financial toxicity associated with this disease. And while the patient is the one formally being diagnosed with the disease, there are far-reaching effects into family and caregivers. There may be family members who feel like they're unable to help or want to do more. There are caregivers who may be so willing to help out, but also have burnout and health issues of their own. The patient may be taking care of a family member who requires their assistance. In so many ways, cancer and its associated therapies can increase the psychosocial toxicity that comes. And I think it's really, really important that we talk about this and acknowledge it during our visits. Once again, important to discuss.
And then just a little bit about the supportive programs and resources that are available at Dana-Farber through the survivorship group, as well as some resources outside of Dana-Farber. So patients are after they finish their cancer treatment can meet with someone in survivorship clinic, and they go through a whole care plan of what's needed in terms of follow-up, but also going through a lot of these concerns about fertility, psychosocial, health behavior, sexual health. They'll go through all of these symptoms to make sure that patients receive sort of the adequate support even after they finish with their original cancer treatment. At Dana-Farber, we also have access to specialty care. So patients may need to see cardiologists, kidney doctors, endocrinologists, who are doctors that work on the endocrine system, meeting with fertility and geriatrics as needed based on sort of their specific situation and what issues they're dealing with after treatment. We also have resources for nutrition and exercise counseling. The Zakim Center has a healthy living after cancer program that a lot of our patients can find very helpful. There's a sexual health program, tobacco cessation program for patients, and resources about social work and psychosocial support. So if you're interested, this is the website. It's a little small about the adult survivorship program at Dana-Farber. This is the Zakim Center, which has lots of options for integrative therapies and healthy living, including exercise, acupuncture, massage. The one-to-one program, which provides support for patients and caregivers with people that have gone through similar treatments. And even at the Y, Livestrong is a great program that works with cancer survivors that are either in kind of any phase of their cancer journey, looking to help them with exercise and supportive care. So thank you for your attention, and we're happy to answer any questions.
Thank you so much, Kathleen and Leah. That was a really great presentation. I know that I learned a lot that I didn't know. As I mentioned earlier, this session was recorded and it will be posted on our Blum YouTube playlist, our Blum Digital Resource Center, and the Survivorship website. So keep an eye out for that. If you have any questions, please type them into the chat and I'd be happy to ask our panelists. So we'll give it a moment for questions, but thank you both so much. Someone wrote in the chat, great job to both of you, and thank you for taking the time to do this. I second that. Someone asked, are gallstones related to chemotherapy?
So, gallstones are very common in lots of our patients. There are some chemotherapies or some cancer treatments that may slightly increase the risk of gallstones, not necessarily just chemotherapy. But it's tricky to know because gallstones are very common, and often people have them for a variety of reasons. But sometimes there may be an association with cancer treatment.
I would just add to that too. There are some medications outside of cancer therapy, sometimes multivitamins and things that you should be cautious of depending on whether you have a history of gallstones. So something to definitely mention to your team.
Great, thank you both. Someone else wrote into the chat. At the Zakem Center, we are also happy to see patients at any point in their cancer journey for integrative medicine consults where we can review current evidence for integrative therapies, provide guidance for such therapies, provide emotional support, and review dietary supplements and follow up as needed.
Yes, the Zakem Center integrative medicine consults are fantastic, and I send a lot of patients there. Dan is wonderful and has been a true asset to a lot of our patients, so definitely recommend.
Someone wrote in that they are having swelling of their feet. What can help them with this?
Yeah, so there are a few things that kind of just in terms of lifestyle that we can do. We can think about the amount of time that someone's keeping their feet down versus elevating. We can think about things like compression stockings. Sometimes we need to use medication to kind of help some of that fluid come off. Things like a medication called Lasix, which is a diuretic. Sometimes we need to think about what is causing the fluid to happen. If it is because someone's having a really hard time keeping up their nutrition and their protein is low, that can lead to fluid accumulating in their legs. So sometimes it requires another evaluation of just their food intake. And sometimes we also need to think about where the surgery or radiation therapy was aimed, because as the lymph nodes get affected, it can sometimes prevent fluid that goes to the legs from recirculating as easily as it might have before that therapy.
Somebody also wrote in what kind of vitamins would be helpful.
So a little depends on the specific person. We often will check vitamin D in some of our GI cancer patients. Sometimes we need to supplement vitamin D. Sometimes patients need to be on iron. We do caution taking sort of supplements and certain vitamins, so it's important that you bring in whatever list that you're taking. We'll sometimes stop certain vitamins, especially high dose ones, depending again on the specifics. So very important to kind of run exactly what you're taking, even if it's not prescription, with your team.
Awesome. Well, it doesn't look like there's any more questions. Thank you again so much for joining us. This was fabulous. And we appreciate you guys coming in.
Thank you.
Thank you.